Welcome, everyone. We're a couple of minutes past the hour, so I think we'll go ahead and get started. My name is Sarah Campbell, and I'm the Associate Director for Medical Science Liaisons with Exact Sciences. And I'm pleased to welcome you today to this webinar entitled Empowering the Patient Voice, Genomic Testing and Cancer Care Decisions. This is being presented by the Academy of Oncology Nurse and Patient Navigators and is supported by Exact Sciences. I'm thrilled today to be here with Jim Green, who is a patient, and Frank Della Rama, who is a clinical nurse specialist. And I'm going to have them both introduce themselves briefly. So Jim, why don't you start?
Well, I'm Jim Green, and I was diagnosed in 2014 with prostate cancer in Denver, Colorado, and I recently moved to just north of Phoenix, Arizona, where I'm being treated here.
Thanks, Jim. My name is Frank Della Rama. I'm a clinical nurse specialist in oncology and genomics, but I've been here at the prostate cancer nurse navigator here at the Sutter Palo Alto Medical Foundation, Northern California.
I do have a few disclosures that I need to discuss before we go any further. So this presentation is sponsored by Exact Sciences. Frank Della Rama is a paid speaker presenting on behalf of Exact Sciences. And any views or opinions that are expressed during this presentation are based on Frank's clinical practice and experience and do not necessarily reflect the views or opinions of Exact Sciences. I am an employee of Exact Sciences. This content is being presented today as information about the use of the tests that are offered by Exact Sciences in accordance with the legitimate use of the products as defined by the company. The information that we present today is not clinical, diagnostic, or treatment advice for any particular patient. And we ask that providers please use their clinical judgment and experience when deciding how to diagnose or treat individual patients. Exact Sciences does not recommend or endorse any particular course of treatment or medical choice. And if you would like to receive additional information on our products, please visit our website at oncotypeiq.com, and we'll display this information at the end as well. So let's go ahead and move on to the agenda. So we're first going to sort of talk a little bit about Jim's story and then talk about what is genomic testing. Frank will then lead us in a discussion about genomics versus genetics and the role of navigators in genomic testing and how important that can be. And then finally, we ultimately want to have a discussion about shared decision-making and how that can empower your patients. So with that, let's go ahead and get started. So Jim, I think I'd love to just get started with having you tell us a little bit about how you were diagnosed with prostate cancer, what that process was like, and how you went about making not only treatment decisions, but selecting a provider as well.
No, thank you. I hadn't had many PSA tests before the age of 60, maybe one or two. I didn't even know what a prostate was at that age. But when I was around 64, 65, I started getting regular blood work done and PSAs. My family doctor noted that my PSA had gone up one year. And he said, I need to keep an eye on it. Well, the next year it had gone up even more. And he recommended that I go see a urologist. A lot of guys like me don't like to think about stuff like that. So I just blew it off. And then the next year he insisted that I go because it had gone up even more. So he gave me the name of a urologist. I went to see the urologist. After a discussion, and looking at my records, he recommended that I get a biopsy. I asked him, well, what does that entail? He told me, and I thought, I think I'm going to get a second opinion on this. And so I did. I did research on the computer. I found another doctor who also recommended that I do a biopsy. The biopsy was done. He confirmed that I actually do have prostate cancer, and that's how this came to be.
Okay, so it sounds like you got a lot of your information from the internet, which is, what we often hear, I think, from our patients. So, um, were you aware of what genomic testing was before you were diagnosed with prostate cancer?
I had no idea what any kind of testing was.
Mm.
I think I'm like a lot of men who we don't pay much attention to that kind of stuff until we actually get involved or diagnosed with something like this.
Sure. And Jim, I don't know that that is necessarily specific just to males. I think there are a lot of women as well who may be diagnosed with cancer who are also unaware of genomic testing. I see Frank nodding. So Frank, what's been your experience with patients and their awareness of genomic testing and how that can help to make treatment decisions?
Right. It's a it's a relatively new word. I think a lot of people in general kind of know more about genetic testing of blood or saliva, kind of looking at hereditary or inherited cancer risk. But I think with genomics, a little bit more new, especially, but I'm glad in prostate and breast cancers, we do have these type of tests where we actually look at the tissue. There's the genetics of the tumor also influences, how fast is it growing? How aggressive does it appear? Because not all cancers are really the same. The information from this type of test, such as the Oncotype GPS score, kind of help us understand the tumor beyond just the pathology report. And I know Jim dealt with early stage cancer to begin with, and I think a lot of, that'll help us make some treatment decisions. Should I just do active surveillance? Should I do treatment? And so I think today the good news is Navigators are a little bit more aware and may bring this up with patients, but I think learning about genomics for all of us involved is the first step for sure.
Great. Yeah, that's a good recommendation. So, Jim, so I know from our discussions earlier, kind of offline, that your doctor was the one that recommended the genomic prostate score to you. So can you talk to us a little bit about that discussion and how he presented it to you, and then what you did with the results once you got your test?
Yes. Well, when I came back from my appointment, when he told me that I actually did have prostate cancer, he went over the different types of treatments that are possible and basically said, give it some thought, and then we'll have another appointment and we'll figure out what we're going to do. Well, I went home without enough information really to make a decision, because I had learned that there are different kinds of prostate cancer, and I knew something about the different types of treatments, but I didn't feel like, without knowing what kind of cancer I had, that I could make a good decision about that. And so it was a tough time, those very few days there where I was talking with my wife and trying to figure something out without all the pieces of the puzzle. And then I got a call from a PA that worked with my urologist, and he told me about, well, he said there's a company in California that can take a look at the tissue and see what kind of cancer it is. And do you want to do that? And I said, well, tell me more. And I said, because do I have to do another biopsy? And I really didn't want to do that. But he said, no, we have the tissue. We keep it for a number of years. And so I agreed. I think this was a great thing, because maybe I could have the rest of the information I needed to understand what a treatment plan should be.
So then they sent your specimen off, correct, and got the testing. And can you share with us what your score was, and then how you and your doctor or his treatment team then made decisions that helped to guide you?
Well, the testing indicated that I had I think the Gleason score was 8 or 10 somewhere. I have to admit some ignorance in knowing those exact type of numbers, but all I know is they said that the type of cancer I had was a slower growing kind of cancer that, and my doctor told me, he said, with this information, there are better options for you. It was like a weight being lifted off of my shoulder, because now I knew I didn't have to really go into some radical types of treatment like removal or different types of radiation. Although those have gotten better, and that was one of the other things I felt like the longer I can put off any type of harsh type of treatment, things are going to get better and better, and they actually have gotten better. But it was a very happy time when I had the rest of that puzzle to be able to make a good decision.
Wow, so it sounds like having that extra piece of information then was really important. And I believe it was your GPS score that was a 10, but having that little extra piece of information then was, you were able to make that type of treatment decision along with your physician. So Frank, can you sort of walk us through how you go about educating your patients when they get genomic testing results back, and some of the questions that they may have about testing in general? And as Jim mentioned, it was sort of, I really don't want to have another biopsy. So how do you walk your patients through that?
Well, definitely, I think the way my practice works is as a prostate cancer navigator here, I get to meet the patient as soon as their biopsy is positive. So a lot of times I'm educating them on the Gleason score, on the PSA, and kind of what risk level they are at. Then we'll have the discussion of, maybe we want to do, if you're low to intermediate risk, maybe we want to do an oncotype test just to figure out if you're a candidate for active surveillance or if you're a candidate for treatment. We kind of bring it up there. And then when the results come in, thankfully either me or their urologist or their oncologist will go over these test results, kind of revisiting what we already discussed at the initial consult. So I believe the navigator's role here within this type of care team is always being an educator, being an advocate to kind of, just like Jim said, there's so much information there. They're scared of getting another procedure, but I think the good news is here, we already have the tissue. We're just going to send it off for genomic analysis. We'll make sure it's covered by insurance, et cetera. So we want to take the burden off the patient as much, but we want them to get this information so it'll really help them come to this treatment decision.
Right. And so I think, there are a couple of things that have come out here with your discussion and Jim's as well. There's no one way to treat a patient, but I think we all have the common goal, navigators, nurses, physicians, that we want to make sure that our patients are armed with all of the information that they need to make an informed decision, and so that they are then satisfied with the decision that they've made. Jim, I think in your case, your physician presented the information to you, and Frank, you do a lot of educating of patients on genomic testing in general. And Frank, you touched on one thing that I did want to mention. So in terms of insurance coverage, of course, that's going to vary based on the test that is ordered, as well as the patient's specific insurance coverage. However, at Exact Sciences, we want to try to make sure that every patient who wants to have genomic testing has access to it. And therefore, we have a genomic access program, or we call it the GAP program, where we can come alongside the patient and actually help with billing and also help with appeals if needed. And so at the end of the presentation today, for the navigators on the line, there will actually be a phone number where you could call. And if you need help with your patient, with their insurance coverage or getting the test covered, you could call that number and they will put you in touch with GAP. So I just wanted to make that clear. So I think we're going to go ahead and move on and talk a little bit about genomic testing versus genetic testing, which Frank had mentioned earlier. And we do have a polling question for all of the navigators on the line. So if we could go on to that. So as navigators, how often do you discuss genomic or genetic testing with your patients? Do you do that regularly? As Frank mentioned, do you do it often? Is it infrequent, or is this something that never comes up in your discussions? So you can go ahead and answer there. Okay, and do we have the results? So it's pretty evenly split. Many of you are discussing the results regularly or often. Maybe about 40% are infrequently or never. So Frank, I'll go to you next and just ask, do you think that those results surprise you at all, or is it about what you expected?
Well, if we would have taken this poll 2 or 3 years ago, I would have expected something a lot different. So that is some progress, but we definitely have some room to grow. Definitely navigators have more awareness. You know, some of us are luckily I have the chance to just serve prostate cancer patients. Some of these navigators out there, maybe they're serving all cancers, so it's hard to know about everything, but I'm glad that the genomic testing is on their plate right now to help their patients.
Right, great. So Jim, since we're talking about genomic testing and genetic testing, were you aware when you were diagnosed of the differences between genomic and genetic testing?
Not at all.
Okay.
It was all
Frank,
new to me.
All of the terminology was new. So genetic testing
Yes.
and genomic testing as well. Okay.
Yes.
Okay. And Frank, so then how do you go about discussing and explaining genomic testing versus genetic testing? Because I think genetic testing has been in the media quite a bit, right? We've had a number of celebrities, especially in the breast cancer arena, talking about genetic testing, and even in prostate cancer with the advent of the PARP inhibitors and their approval. So can you walk us through just a little bit how you explain the differences to your patients?
Yeah, definitely. I mean, even with genetics, genomics, there's so many different words and terminology. Even it gets confusing for even us as providers. But I think when it comes to genetics, we're thinking about genetic testing of the blood or saliva, and that would be more about hereditary or inherited risk related to the BRCA1 or 2 genes, which are related to breast, ovarian, prostate cancer. So that's a different type of testing. We're testing the person. In genomics, we're usually testing some type of tissue, like in prostate cancer, either the biopsy or the surgical specimen. So we're really looking at the genetics of the tissue because we can understand, you know, is it going to be more dividing more aggressively or less aggressively? And that will help us kind of give treatment recommendations if a man is on the fence about, oh, should I treat it? Should I not? Yeah, a lot of times the GPS score will really give them that information where they're going to be, yes, I want to do active surveillance, and yes, I'm going to be comfortable with that information looking back. I think the good thing about having this type of test up front, what we found is that with patients who had the test a while ago and they made their decision to do whatever they wanted to do, they're satisfied with that decision, even looking back, even if the outcomes are not ideal. Having a lot of information up front is really going to have the patient avoid the woulda, coulda, shoulda. And so hopefully they'll make a sound decision that they can own.
Exactly. Right. We don't want them, we want to avoid any of the woulda, shoulda, coulda. So for those of you who may have just joined, my name's Sarah Campbell. I'm the Associate Director of Medical Science Liaisons for Exact Sciences, and I'm having a discussion today with Frank De La Rama, who's a clinical nurse specialist and a prostate cancer navigator, and Jim Green, who is a prostate cancer patient. And we've been discussing genomic testing, and we're now talking a little bit about genomic testing versus genetic testing. And so I think if we go on to the next slide, we are going to talk a little bit about some of the Exact Sciences precision oncology tests. So Jim had the genomic prostate score test, which is specifically for men with early stage prostate cancer to help them make a treatment decision. Basically, should I have surgery or not, or radiation or not? We also have the early stage breast cancer test, which is known as the breast recurrence score. And this helps women and their physicians to make the decision about the receipt of chemotherapy or not. There are 2 other tests that are available also in the early stage. One is the breast DCIS score. So for women who have stage 0 or carcinoma in situ of the breast, this can help to give them a prognostic score that may help to determine whether or not they are a candidate for radiation therapy. And then finally, we have the colon cancer recurrence score, also for early stage, for patients with stage 2 colon cancer that's MMR proficient, or for stage 3 A or B colon cancer. And again, this is a prognostic test that can help patients and their physicians decide about chemotherapy. Then for those patients who have later stage cancer, we also have the Oncotype DX ARV7 nucleus detect test. This is specifically for men who have metastatic castrate-resistant prostate cancer. And if they've been treated with one AR-targeted therapy, so something like enzalutamide or abiraterone, and they progress, this is a blood test that can actually help to determine if they would be a candidate for a second line of that type of therapy, or if there's somebody who perhaps should move on to receive a taxane chemotherapy. And then finally, also for metastatic cancer patients, we have the Oncotype MAP pan-cancer tissue test. This is, again, a tissue test. It's next generation sequencing. So oftentimes with lung cancer patients in particular, this is information that's really needed to help guide treatment decisions. We look at 257 genes to determine if patients have specific mutations and might be candidates for targeted therapies. So as Frank mentioned, there's oftentimes there is new information that's available to navigators, and particularly for those of you that may treat or may see patients with multiple diagnoses, we do have a full array of tests. And if you need any additional information, again, there will be both the website information as well as a phone number that you could call for more information. So I think if we go on to the next slide. So now I'd really love to just dive into the role of nurse navigators in genomic testing. Frank's touched on this a little bit, but if we go on to the next slide, we do have another polling question for all of you. So as navigators, how are you involved in the genomic testing process? So, from discussing with the patients, but not necessarily discussing the results with them. Some of you may discuss the process as well as discussing the results with patients. And some of you may not be involved at all. So go ahead and respond to that question. And hopefully everybody's had a chance to respond to that. So let's go ahead and take a look at the results. So, okay, again, almost 50% of you discuss the full process with your patients, but not necessarily go over the results. So probably the physician is doing that. A few less discuss the whole process, and then about a third aren't involved in the process at all. So, okay, well, Frank, I'm going to turn this over to you to sort of give us your thoughts on the polling question there.
Yeah, definitely. I'm glad a majority of navigators are involved in the process, and kind of some are discussing the results. Definitely in my practice, I do discuss the results, but it's not really, it is a team effort. So, it's not that I'm not always the first one to give them the news about the GPS, but in a team situation, me and the urologist and the oncologist, we kind of know how we feel about the testing. So, a lot of times I'm sharing them the results either on a phone call, or I'll mail it to them ahead of time or email it to them ahead of time. And I'll give them some of the links that the company has about explaining what the test report means. And so I think the role of the navigator here is just, again, to be educator, to be advocate. I want to make sure they understand now this test that they've gotten, and how does this now play into my decision. And so if under the microscope my cancer looked intermediate risk, but then and now genomically it looks low, we'll have a little bit more discussion about active surveillance versus the other way around. Perhaps treatment sometimes is favored over active surveillance for some men, either by personal preference or from getting tests like the GPS as well. So I think again, it's all about navigators, nurse and patient navigators, kind of making sure that patients get the information. Thank you.
Sure. Yeah. And I'm sure you probably get questions after the fact, right? If they've had that discussion with the physician. And as Jim mentioned earlier, a lot of times you think of questions after the fact. You've walked out of the doctor's office, you've had the discussion, and now you think of something. And so I'm sure that navigators play a vital role in the patient picking up the phone and saying, I think he or she said this to me, but can you sort of walk me through that? So, Jim, I believe you've told us that it was your physician that gave you the results of the test. And so, was there any additional education then that you received once you got the result of your GPS test?
No. My physician gave me the test results, as I remember, over the phone.
Okay.
And I had met with him twice. The initial one time, the results of that I did have cancer, but then when I found out about the genomic test, it was over the phone, and then the results came over the phone. And there wasn't a nurse navigator or patient navigator involved, but I can tell you, it would have been easier to go through the process had there been someone like that. It's not just the physical part of it, it's the emotional part of it, the mental part of it. Because at first, when you hear the word cancer, I know a lot of men, it's like, I have cancer, get it out of me, just surgically get it out. And I've talked to numbers of people who said, well, gosh, I had the surgery right away. I don't even know what kind of cancer I really had. I just knew I had prostate cancer. And I just wonder personally how many people made bad decisions because they didn't have all the information and some help with processing the information. Because you don't think as clearly once you hear the word cancer at first, and it takes a little while for things to settle in. And, I talked to my wife, but she was more upset than I was. And so we could really use someone like a navigator that it would have been really made the process a lot easier.
Yeah, it sounds like, you did have the information that you needed to do that shared decision making, but perhaps that extra layer of support there and somebody else to discuss it with might have been really vital. So let's go on and talk a little bit about shared decision making and what that really means. First of all, I guess, Frank, I'll ask you to maybe give us a definition of what you think shared decision making really means.
Sure.
And then Jim, once Frank's done that, then we'll bring you into the conversation too about what it meant to you.
Yes, Sarah, I'll tell you, my role as prostate cancer navigator actually was born out of a research study about shared decision making. So shared decision making is really the act of, a provider like myself working with a patient and the whole caregiver team to kind of do their due diligence. And so we're really not telling them what to do. We're helping them evaluate all the pros and cons of everything about whatever the situation is. And in the end, we'll come to a decision about what we want to do as a team for the patient together. And so, in cancer, there's always these decision points, whether it be like Jim, should I treat or not? Whether it be I have breast cancer, should I get chemotherapy? Or if I have another cancer, are there targeted therapies available? So, these are decision points that as nurses and as providers and even patient navigators were discussing, but then with the genomic scoring, perhaps it's going to help with some numbers around helping patients come to these decisions. So, shared decision making is key now in healthcare, and a lot of times navigators are part of that process and work with the doctors and the patients and even the caregivers, because we want them to understand all the pros and cons of every option. So when they pick an option, they're not going to be like Friends of Jim, where they did it blindly, and they kind of, should I have done this? Should I have done that? And so I think with this type of activity in any part of healthcare, we want to inform, shared decision making. So the patient is going to be the one who's owning this decision 5, 10, 20 years down the line. So it's important for patient and caregivers to have that voice with a team. And I think shared decision making is a great concept to kind of help get that done.
Yeah, well, thanks for that really great definition. And that's really exciting that your role was born out of research about shared decision making. So, Jim, I know you've shared that you felt like you had the information that you needed. And did that really make you, I'm not going to put words in your mouth, how did that make you feel to have the information that you felt like you needed?
Well, clinically, from my urologist, he was very as a matter of a fact. Okay, he gave me the information, and he was busy. He was a well-known person, and so he wasn't gonna, and I could tell you, he was going to give me information and as accurate as he possibly could, but there wasn't going to be a lot of discussion about it. And there wasn't going to be it's hard to say, but there can't be as much empathy as a person that's in your position, because you have that part of it is the other part of it, not just this is the facts, like Sergeant Friday, just the facts, ma'am, just the facts. And I really would have liked to have had somebody in the loop like that, because I didn't want to talk to my friends. They don't know. They didn't know. They didn't know what it was I was going through. And my wife, she had a lot of emotional investment in it, and was scared. So a person who is empathetic can give you the facts, but then kind of ease the landing, I guess. But in the end, ultimately, I haven't asked anybody, tell me what to do. I've made my decisions, and I take full responsibility for them. I've been on active watch now since 2014. My PSA has gone up and down. I've been told maybe it's time. I thought, well, I don't think I'm quite ready. My PSA went down. I had another biopsy. The results showed that I made the right decision. But whatever the decision was, I take the responsibility, and it's my life. So that's the way I look at it. But a nurse navigator, patient navigator would have been really a really good sounding board, and maybe taken some of the emotional part of it out so that the decisions are sound.
Yeah, those are all really good points. And I think, again, it just sort of, emphasizes just the importance that all of you navigators really play, not only with the patients, but with their families as well, as they are making these important treatment decisions. So thanks, Jim, for sharing. And I'll just note that Jim does have a video on our website. And so if you want to hear a little bit more about his story, you can go and watch that as well, and share that with your patients also who are making treatment decisions. So I think at this point, I'm going to just walk through some patient examples and show you some of the patient reports. Many of you may be familiar with these patient reports, but the first one that we have is for the Oncotype DX breast recurrence score. This, as I mentioned before, is for early stage breast cancer, and specifically for women who are hormone receptor positive and HER2 negative. The particular patient in this case was 67 and was postmenopausal. She had a 1.6 centimeter tumor that was an intermediate grade or a grade 2. She was lymph node negative, and as I mentioned, she was ER and PR positive and HER2 negative. And she got a recurrence score of a 15. So let's go on to the next slide, and then I'll talk a little bit about just what the results mean. So in that first box there, with a recurrence score of 15, that gives the patient and her physician and her treatment team an idea of what her distant recurrence risk is, as well as the absolute chemotherapy benefit. The second tile there then shows what her distant recurrence risk is. And you can see for a patient with 15 who's postmenopausal, it's about 4%. And really, the most important thing with making that chemo decision is that last box there, which shows that for this patient with a score of 15, she's not going to benefit from chemotherapy. And so this is the information then that the physician and the navigator might discuss with the patient to help make that chemo decision. And then there's supporting information there as well from both the TAILORx and NSABP studies. We also then have a different report for patients who are node positive. And then if you want to go on to the next slide, the third page of the report then gives distant recurrence risk curves. So again, this is for early stage breast cancer. If we go on to the next slide then, this is going to take a look at the Oncotype DX Genomic Prostate Score, or GPS score. And this is what the test that Jim received, that they were able to submit his core biopsy, and then we were able to analyze the genes in that core biopsy. Again, this is for early stage prostate cancer for men who are trying to decide if they need to have a radical prostatectomy or not. So the patient in this case was 56 with a Gleason score 3+3. So this would be a patient with low risk disease. He had a PSA of 5, and he had 1 out of 12 of his cores that were positive. His GPS score result then was a 12. And if we go on to the next slide, it's going to show us blown up a little bit, if you will, what that first page of the report is going to look like. So the low risk patient report has recently been amended. And so for those of you who've ordered this test, this may look a little different from the report that you've seen before, but always up at the top, you're going to get clinical information that was presented to Genomic Health, or excuse me, Exact Sciences from the physician. And then the GPS result then shows where that patient falls in relation to other patients who have a similar clinical risk. So you can see for this patient who has a GPS score of 12, he is in the low risk group, even compared to his peers who had similar clinical characteristics. And then finally, the likelihood of him having an adverse pathology, meaning that he would have a higher Gleason score or extracapular extension. If he had a radical prostatectomy, for this patient, his likelihood of having adverse pathology is low. And if we go on to the next slide, then there's additional information that is given on the next page of the GPS report. It also looks at the likelihood of that patient either having high-grade disease or non-organ confined disease. And then finally, the risk at 10 years of having metastatic disease due to his prostate cancer. This would then be based on a patient who did go on to actually have a radical prostatectomy. Then if we go on to the next page, this is our newest test that's available again. This is called the Oncotype MAP Pan-Cancer Tissue Report. This is NGS testing, and so is specifically for patients who either have advanced non-small cell lung cancer or who have metastatic disease of any solid tissue type. We give you a very easy to interpret report. One of the key features of this test is that the other tests in the Oncotype suite, you can expect to get results within about 2 weeks. With NGS testing, we do give you results within 3 to 5 business days once you receive the sample in our lab. And then you get this report. And so it gives you information on any NCCN guideline recommendation treatments. and things that are approved by the FDA for the specific patient. You will then next see high-level interest markers. So, for instance, for non-small cell lung cancer, of course, we want to know if these patients are PD-L1 high, which might make them eligible to receive immunotherapy. In this particular patient's case, they were ALK positive, and so there were a number of targeted therapies that might be available to the patient first. And then we go on to give you additional therapeutic options. If you want to go on to the next slide, then it also gives you additional information about the specimens. We can run this test with a specimen as small as 3 millimeters squared, which is about the size of a grain of rice. So for your metastatic patients who we oftentimes have difficulty getting adequate tissue from them, we can process this on a very small tissue specimen as long as we have about 15% tumor cellularity. And then the report goes on to give you other salient findings. And then on the last page of the report, which is on the next slide, we also outline clinical trials that might be available to your patients. So again, this gives you information that for patients with metastatic or advanced disease. Okay, if we can go on to the next slide then. I'd like to just cover some of the resources that are available for you to educate your patients. So we do have our Oncotype IQ website. Again, that's oncotypeiq.com. And on there, you will find just a myriad of information available. So we have a couple of patient information handouts that you can see here. One is for the Oncotype MAP test, and the other is for the GPS test. If you go on to the next slide, then there's also information about the GAP program, which I mentioned. And then there's also available for you to either show your patients or give them the website information. They can go on to view videos of physicians who are discussing the particular test types and how to interpret testing results. There are also, as I mentioned earlier, actual patients who have videotaped their story, and they talk a little bit about what genomic testing meant to them. So I would just encourage you, if you haven't before gone on to the website, to look at the available information. Of course, you can also get all kinds of information from your Exact Sciences sales reps as well. And if they need to put you in touch with any of our medical science liaisons, they can do that as well. So if you want to go on to the next slide, we are now going to just move on to the Q&A session. But before I start to answer questions, I really just want to thank Frank and Jim for their time. Jim, for being just so frank and honest with us, and Frank for sharing all of your wealth of information about what it means to be a navigator and how your center has developed their program to really help to empower patients with knowledge and sort of help them through that treatment-making decision process. So thanks to both of you. And you're not off the hook because some of these questions may actually be directed to you. So don't think that you're off the hook right now. Okay, so let's go on. Before we do this, I just want to mention again the website. So oncotypeiq.com, where you can find product information, you can find patient information. And then here is the number to reach customer service and our GAP program. So it's 866-ONCOTYPE. Can patients receive their test result reports directly from Exact Sciences? And so because the report is really such an important part of that shared decision-making process, we really encourage the patients to reach out to their healthcare provider to receive a copy of the report from them, and then also to discuss the results with their HCP, because the information in and of itself in a vacuum is not what's important. It's where they can actually have that discussion with their healthcare provider about what the results means and how that may actually impact their treatment decision. So I have another question that has come in here. It says, did I state 15% or 50% cellularity? And it is 15% cellularity is what we need in order to process, in order to extract adequate DNA really from that tissue so that we can run the test. I will also mention, though, that if we are unable to process the test, either because we find that there's not adequate cellularity or there's just not enough tissue or for some other reason we're not able to process, we will give you a report that says that there's QNS or quantity not sufficient to process within 48 hours so that you're not waiting for a week or two to find out that we were not able to run the test. I will just mention that this does happen somewhat frequently with bone specimens. So for prostate cancer and for breast cancer patients, where oftentimes you may only have a bony lesion to be able to test, we ask that that is not decalcified using a strong acid because that will denature the DNA and then we're not able to process. So the next question is that, are there any other tests in development for other cancers? So the answer is yes and no. So we are always, as a company, looking for new tests to develop. And so we have two different sides of our business. I actually work in the oncology side of the business. We have screening business as well. And so you may be familiar with the Cologuard test. We also recently commercialized a liver cancer test as well. And we are currently working on a multi-cancer screening panel, which would then ultimately become part of the screening suite of products. On the oncology side, we acquired a company called PFS Genomics, which has developed a radiotherapy signature for early stage breast cancer. And so we are doing further validation studies for those two tests. One is to determine if you are somebody who could avoid radiotherapy totally. The other is a signature that looks to see, okay, if you're somebody who gets radiation and really doesn't respond, do we need to treat you more aggressively? So again, those are in the development stages. There was a poster that was presented at the San Antonio Breast Cancer Symposium last week on the ongoing development there. And then I will just say as a company that we hope to be able to help patients from the time of screening until metastatic disease and to be the provider that can provide them a whole suite of tests so that they and their healthcare providers can help to make informed decisions. So just stay tuned for what's next to come. And then finally, I had another question that came in. So who are the stakeholders that are involved in analyzing the tissue sample and sending the report results to the office? And so we have a whole lab that is dedicated to this. And so it starts with our pathologists who first review specimens as they come in to confirm the diagnosis and also then to note, where the specimen should actually be sampled from. Where's there the most tumor tissue and where should we sample from? We have lab technicians who are, specially trained to process the specimens. And so once the specimen comes in-house, so if it's for the Oncotype GPS test or for the breast test, those are processed in California. Others go to Phoenix to our labs there, but there are a number of people who are involved. And of course, it all starts with your local pathology department. And so, once you request the pathology specimen, you would ask that in order to expedite the results, that they would send that to us in an expeditious manner. I apologize for the voice going in and out. Those who know me well will know that this is the best I've been able to talk for about 3 weeks, but it's starting to fail me now. So I have another question that's come in here. So if a patient had lung cancer 5 years ago and now clinically appears to have a recurrence, can the original tumor tissue be tested? Would it yield any important information as opposed to testing the new tumor? So I would say that for lung cancer patients, one of the important things to know is, have they developed any new mutations while they have been on active treatment? If they have been on active treatment, then our preference would be to test a new recurrence lesion, because that will often give you additional information that may be very important to how you treat the patient. So let's say that they have progressed on osimertinib, which may be given in the adjuvant setting. We would want to know, what those mutations were, because it might then impact how you make treatment decisions. For something like prostate cancer, for instance, we have tested specimens that were older, and we have been able to get important information from those specimens, but our preference is always to get a new biopsy specimen if that is possible.
Sarah?
Yes.
I just may want to add, about a year ago, my oncologist found another nodule on my prostate, and they did another biopsy and sent in new tissue. It confirmed that it was the same cancer, but it was a good confirmation, because as I understand, you can have more than one type of cancer on your prostate.
Yeah, that's right, Jim. And so, they wanted to make sure that your prostate cancer had not progressed to a more aggressive type, which then, might have indicated that you needed to have more aggressive therapy at that point in time. And then I have a question here that I may have answered this already, but what is the difference between the Prolaris testing versus Oncotype genomic prostate score? And so both of these are going to test tumor tissue. They're going to look at specific genes within the prostate cancer tissue. How they report the results out does differ somewhat. And so, we could do a whole discussion about the differences between the two tests, but essentially, Prolaris will give you prognostic information, and the Oncotype test will give you that information about your risk of having adverse pathology if you should have your prostate removed. I will just say thank you all so much for tuning in today. Thank you for sending in the questions that have come in from the audience. And thanks again to both Jim and to Frank for sharing their input and their insights. As I mentioned before, this program has been recorded. And so if you have colleagues that you feel might benefit from hearing this information, please, just point them to the AONN website, where they will be able to access the information. And thank you so much.